Hi everyone, I hope you guys are doing okay, staying safe. Um, Today we're going to talk a little bit about conduction disorders. So here are the common conduction disorders, right? We've seen all of these things before: AFib, A-flutter, AV block, bundle branch blocks. We diagnosed all of these when we were talking about EKGs, of course. Fortunately, for today's lecture, we're really just going to focus on atrial fibrillation, the management of it and the diagnosis of it, and the different types of AFib that you'll see out there. It's really an important family medicine topic. Not that, a lot of the critical decision points on the management of AFib is done by cardiologists, but as family medicine practitioners, we'll be following up on patients that are going to be on some very strong and dangerous medications. So we've got to be familiar with the types of managements that go on with AFib. A lot of those other things, when we talk about arrhythmias, those are going to be covered when you guys do your ACLS module in a lot of depth and a lot of practical use. So it's a really great class. I think a lot of people, or it's a really great course. I think a lot of people get nervous at it because it's a lot of hands-on things and you're running codes and things like that. It's nerve-wracking, but it's like super exciting at the same time. So I'm excited for you guys that have never taken an ACLS course before to be able to do that because it's fun. Here are the objectives for the lecture today. We're just going to really talk about the pathology and the etiology of atrial fibrillation, some general statistics about atrial fibrillation, how to diagnose it, how to identify atrial fibrillation when it's suggested by an EKG, how to know make sure you know the different types of atrial fibrillation, and then we're just going to go into the basics of the management and treatment. So knowing about rate and rhythm control, and then about anticoagulation for stroke risk management. So let's get to it. Atrial fibrillation. Just reviewing basically what we talked about before, when we think about what atrial fibrillation is, remember it's one of those arrhythmias that really covered a bunch of different areas when we talked about the pathology and arrhythmias. So it is an irregular heart rhythm, right? So not only were the patterns between the R waves irregular, but you couldn't predict them, okay? And there was no pattern, so they weren't the same, and there was no pattern to them. Remember that it's also an irregular rhythm and a tachyarrhythmia. Okay, so when you think of the specific pathologies that are involved with that, you've got a set of tissues that have an entrance block, which causes the irregular rhythm, and you also have foci that are very irritable. So not only do these tissues act with their own automaticity, but they also fire randomly and rapidly. So that's really what brings us to what we see when we think of as AFib. There's different types of AFib, and it's just it's a lot of definition stuff here, but it really helps us in how we decide management and treatment. So when we talk about paroxysmal atrial fibrillation, the episodes here, they occur for less than 1 week, right? They last less than 7 days and they're generally less than 24 hours, but definitely less than 1 week. If you have an episode of AFib that lasts more than 7 days, well, then that tends to be called persistent AFib, okay? When we talk about long-standing persistent AFib, now that's AFib that's been going on for 12 months or longer, okay? And then when you have permanent AFib, that's just the definition of when you and your health provider, or when the health provider decides that, okay, we're not really going to try to do any more what we call rhythm control. We're not going to try to stop the AFib or convert to normal sinus rhythm. It's just permanent at this point. Now, when we talked about arrhythmias, I feel like I had made a comparison between atrial fibrillation and ventricular fibrillation, right? Obviously, atrial fibrillation can be chronic, and patients can survive chronic atrial fibrillation, right? They're walking around right now with this arrhythmia. And that's because, from a cardiac output standpoint, just because the atria can't contract doesn't mean you're not decreasing your cardiac output by 100%, right? You're just going to lose a little bit of the contraction at the very end of the ventricular filling that the atria push into the ventricles, and it's not that much, right? Most of the ventricular filling from the atria is gravity fed. So it's not that big of a loss from a cardiac output standpoint. From ventricular fibrillation, which if that's not, you don't have coordinated contractions there, well then that's a major issue. So yeah, when you compare the two, ventricular fibrillation versus AFib, obviously, VFib is way more dangerous on a very acute level, but it doesn't mean that AFib is harmless. One of the major things that we worry about is the risk of stroke increases by a lot. You have that poor atrial contraction that happens, and so it's just that quivering muscle. You get blood pooling, thrombi form, and then if they break off and shoot off, then you've got either a pulmonary embolism type situation, or you've got stroke. So that's a problem. And then the other issue is congestive heart failure. Again, from that poor atrial contractions. If it gets bad enough, well then yeah, you can start to get poor ventricular filling, but really it's the congestion of not being able to push blood out quickly enough. So then you've got backup into either the lungs or the lower limbs, depending on which vessels are involved. The other thing that makes this a very tricky disease too is that it's a degenerative disease. And what I mean is that this electrical dysfunction that happens causes an inflammatory activation within the atria walls themselves. And so you've got all this inflammatory attacking the muscle tissue, you've got myocardial loss and fibrotic tissue deposition, which then leads to more problems with the cells becoming having their own automaticity and having more issues with rapid firing and random. So this causes a progression, right? You may start off with atrial fibrillation that is just paroxysmal, but because of the ensuing damage that keeps going, you've got persistent, and then you've got long-standing persistent, and then eventually you have to have a permanent AFib. So this is what drives a lot of the management, where it's not just about saying, okay, the person's cardiac output is okay. Do we really strive for having a normal sinus rhythm at that point? Okay, and we'll talk more about this later, because this is the real controversy with this disease. Is, are we okay with the fact that the person has an appropriate cardiac output, or do we really go through measures that can help get a normal sinus rhythm? So when we talk about what causes the pathology of this disease, the biggest thing is hemodynamic stress. Okay, and the way to think about that is basically, if you have too much pressure within the atria, they get stretched out. That stretched out tissue again starts to cause irritation, and then that's where you get cells, myocardial cells, that tend to become, lose their entrance block or become irritated and agitated. So you can see where just again, physically causing stress on the walls causes the creation of those automaticity sites, which is the more of them that are there and the more irritated they are, there's your AFib. Probably the most common thing that causes hemodynamic stress on the atria are problems with the valves then, okay? So either the mitral valve or the tricuspid valve disease. If you have regurgitation or prolapse, that's going to cause more stress on the atria because there's going to be more blood there because it's just not moving through effectively. Obviously, if you have mitral valve problems, then you're going to have left atrial issues more, which mean that any thrombi that form here are going to end up as a traditional cerebrovascular stroke. If you have tricuspid valve disease, well, then you're going to have issues with stretching of the right atrium, more damage there. That's where the thrombi form, and then those will end up as pulmonary embolisms, or pulmonary emboli. And so, because the prevalence of mitral valve disease is higher than tricuspid valve disease, you tend to see more stroke related to it. But again, it really is more where the thrombi form is what ends up as the complication. A common reason for atrial fibrillation and stroke are patients from a long time ago that had rheumatoid valve disease. Right, they have rheumatoid fever. They generally have mitral valve problems, vegetations, and so that's the beginning of their atrial fibrillation. As far as some of the general statistics of atrial fibrillation, it is the most commonly encountered arrhythmia. Probably because a patient that has it doesn't just fall dead. Like I said, it's a chronic disease, so someone can have it for a long time. Joe Biden here, you can see he's getting non-valvular atrial fibrillation. So it's not because of any damage to his valves. He has a specific atrial fibrillation that's not due to that. And he's got a normal ventricular response, which if you remember from our EKG lecture, that means that even though he has atrial fibrillation and he has those constant firing of his atrial tissues, they're not rapidly getting converted into ventricular contractions, and we'll come up that in just a few slides here. But you can go through that, and it's interesting stuff. You'll by the end of this lecture, you'll understand everything that's going on there and why. Basically, the picture that his doctor is painting is that this is a very benign form of atrial fibrillation. But up to 6 million affected the United States, and a lot of it is prevalence. Prevalence is age dependent. Sorry about that. And a lot of that has to do with the fact that people have these valvular diseases later on in life, and even if they have evidence of valvular disease earlier in life, those symptoms don't, or at least the pathology doesn't tend to cause atrial fibrillation until later. Okay, so if you're younger than 55 years old, you're probably not going to have it, but it shoots up to 4% after 60 years old, and doubles after that when you're older than 80. So it rises pretty rapidly. Up to a twofold risk of death, mainly from thromboembolic events. So we talked about the stroke risk there, so it's pretty bad. And of course, it's associated with heart failure too, which we talked about. Atrial fibrillation tends to have two different presentations, right? There's the patients that get diagnosed after going to the ER for other symptoms like congestive heart failure, hypotension, or they can actually have angina, ischemia. So the cardiac output really has gone down at this point, or like I said, it's from associated things like CHF. It's difficult because patients, they can describe, right, the palpitations and things like that, but they don't generally go to the ER for those types of things. So that's obviously when there's more severe symptoms. And then there's the more benign symptoms leading to just like a clinical visit. So yeah, patients talk about having palpitations. They can feel their heart beat rating fast, or they have nausea or fatigue or poor exercise tolerance, or they pass out, or they feel like they're going to pass out. They get really lightheaded and dizzy, and maybe even before they black out. Dizziness, generalized weakness, right? Nothing very specific here that would suggest atrial fibrillation, other than, okay, both of these situations deal with low or disrupted cardiac output. The physical exam findings tend to be really nonspecific too, right? It's not like you can hear atrial fibrillation. So tends to be nonspecific, related to the specific presentation, right? If you're going to the ER because your cardiac output is really compromised and you've had long-standing AFib and you just haven't realized it, well then you may have CHF to go along with it. Some of the specific physical exam findings, right? Cardiac auscultation may reveal some murmurs from the valve disorder, right? They may not if it's a really slight valve disorder. Pulmonary auscultation may reveal wheezing, rales, suggestive of heart failure. But again, if you are just assuming it's heart failure without anything else, you may not get an EKG and catch it. And then, of course, if you've got heart failure, you also may have some lower limb edema too. So it's always something to keep track of. Remember, 8% of patients over 80 and 4% of patients over 60 can have those atrial fibrillations. So hopefully you guys already knew what atrial fibrillation looked like on an EKG. It's a pretty specific looking rhythm, and we've talked about it already too. So obviously you can diagnose this with an EKG and just look at the, what the electrical activity suggests, right? You've got some normal, narrowish looking or normalish looking QRS waves, but the atrial activity really suggests just quivering, muscular, uncoordinated contractions, right? So with the atrial activation rate being about 350 to 600, right? That's what separates fibrillations from the slower flutters. So yeah, just really uncoordinated, nasty looking, no P waves or anything like that. Remember that there's a difference between whether or not the electrical activity gets communicated into ventricular contractions. As long as the ventricular rate is normal, then we call that controlled atrial fibrillation, and those tend to be asymptomatic, okay? The problem becomes when you've got a lot of communications between the atrial activity and the ventricular activity, and now you've got tachycardia. So that's known as uncontrolled atrial fibrillation or rapid ventricular response. Those definitely tend to be symptomatic, and at that point we tend to be pushed towards more procedural or more ablation type techniques as opposed to just pharmaceutical control. Now, one of the tricky things about diagnosing atrial fibrillation is the fact that early atrial fibrillation is paroxysmal, right? It doesn't start off as persistent. It's a progressive degenerative disease that turns into persistent or permanent arrhythmia. But for patients that have just a recent onset of atrial fibrillation, those episodes can last for a few hours, minutes, but it's alarming because patients can tell when they've converted into atrial fibrillation, right? There's those palpitations that go on and most real commonly nausea that goes along with it. So how do you test for atrial fibrillation that the patient may have had, but maybe is not currently having it, right? If the patient is currently feeling the palpitations, then you put an EKG on and you can see the rhythm right there. But of course, that's not going to be the common situation when they first start having these arrhythmias. So there's two different types of monitors, and they're both pretty common these days. And I'm just going to give you some basics on them because there's obviously a lot of overlap between these two things now. But the very basic, when someone says a Holter monitor, they're talking about a monitor that is going to measure and record continuously for 48 hours. Okay, so if it was printing on a piece of paper, which they don't, they just record them, then it would be a piece of paper that was 48 hours long, basically. Cardiac event recorders are another type, and they can be worn by the patients for up to a month at a time. And again, it probably has changed now. Maybe they're longer. But the recording only happens when the patient signals it to be recorded. So they'll hit a button when they're feeling palpitations. Okay. So obviously there's a lot of benefits to both of these things. If the patient is more likely to just have palpitations throughout the day, if they can tell you, yeah, I at least have it multiple times a day for hours at a time, well, then you can do a Holter monitor and you can really measure how long those episodes are, right? And you can diagnose it that way. But if a patient really has a paroxysmal one and they say, yeah, I kind of have it, I know I have it every couple days, maybe every couple of weeks or something like that, well, then probably a cardiac event recorder is going to be the way to go. This guy, obviously, he loves having cardiac disease. Super happy there. Another test to think of is an echo, right? If you diagnose AFib, don't just go start treatment. You've really got to look for the associated diseases, okay? So an echo is a really good thing to look for because, again, a lot of these atrial fibrillations are started by valve dysfunction. So transthoracic echo is good for characterizing valve structure. And then transesophageal echoes, or TEEs, they're more useful for looking for actual thrombi that may have formed. So it's, you know, again, this is a decision that's got to be made here. If you're really concerned that the patient may be having atrial thrombi because they've had more long-standing, or maybe not even long-standing, but it's not just a recent finding that they've had AFib. Maybe they told you that they've been having AFib for the past couple of months. You'd be concerned that they might have some thrombi that are just lodged in there. So a TEE would be a good way to go. The other reason why TEEs are done too is when you are thinking about doing cardioversion, okay? And so cardioversion increases the risk for throwing an emboli. So you've got to do these too when cardioversion is considered. So it's, you know, I'm not going to quiz you guys too much on this, but just kind of know the difference between these two things, right? TTEs are better for characterizing valve structure, but TEEs are better for looking for a thrombus, but it's a more invasive procedure, okay? Okay, now we're going to talk about the very basics of management. When I say basic, I mean very basic for this, okay? So first off, for family medicine, the rest of this is referral territory, right? It's making these decisions. There's a lot that goes on to it, and it takes a lot of expertise to kind of deal through this. But you know, in general practice, we're going to have to follow up on these medications. So regardless of the strategies taken, you're dealing with a lot of heavy meds here. So we've got to be at least familiar with the strategies. We're going to start with just describing rate versus rhythm control. And these are two separate strategies of dealing with any arrhythmia really, but we're going to focus on atrial fibrillation. Okay, so rate control versus rhythm control. In rhythm control, this is actually trying to restore normal sinus rhythm. Okay, so there's two different types of ways to do this. Is pharmacological, and depending on where you guys are right now in your cardiology pharmacology, you've probably talked about these medications. So flecainide, propafenone, dofetilide, and amiodarone. Amiodarone is probably the real big common popular one for basic atrial fibrillation. But again, for those of us that are like familiar with medications, these are not common. Yes, they're common for arrhythmias, but these are real nasty medications that you've got to be really careful with. And if someone's on these, you know they've got an arrhythmia issue that you've got to be careful of. Okay, so they're big drugs. The other type of cardioversion is direct current, right? And it's exactly what it sounds like. It's an electrical cardioversion. So it's basically a form of defibrillation. And then there's also ablation cardioversion, which again, if you really think about the pathology here, you're working with agitated, irritated tissues that are self-firing rapidly and randomly. So if you get rid of those specific sites, well then you can get rid of the atrial fibrillation. So that's what ablation is basically burning those tissues away and killing them so that they're not randomly firing anymore. You guys know that I put pictures on here sometimes that are, you know, a little less than helpful, I guess, as far as what's going on with the slide. This is a picture that I think is still not that useful. I'm not really sure what you're supposed to learn from this description of cardioversion. Like, Okay, I get, yes, it's probably a machine that's going to help. Sure, cardioversion pads. I mean, the machine's got to be hooked up to the patient somehow. And then an IV line. Okay, great. Um, I mean, the original slide doesn't say man. I edited that, but it said doctor, which, again, I don't really know how useful that diagram is. The alternative strategy is rate control. Okay, and that's using medication to keep the heart less than 100 beats per minute, or at least to keep it from being tachycardic. Um, the less than 100 BPMs, that's a relatively newer recommendation. The recommendations were upgraded in 2014 and then again really recent in 2019. And the studies show that the strict control that people used to do, less than 80 BPM, it just showed less efficacy and actually more issues because, again, when we're trying to keep it under 80 beats per minute, that just means that we're trying to use more medication, right? So the balance, it just didn't pan out. That keeping it under 80 was actually more beneficial to the patient than just keeping it under 100 BPM. So that's rate control, the basics of it. This is tricky, right? The choice between rate and rhythm control. This is the part of it where it's beyond family medicine at this point. It's not going to be the family doc that chooses. It's going to be a cardiologist that's really familiar with all these different medications and techniques and with all the different types of patient populations that atrial fibrillation can occur in. So this is tricky. And again, I just want to bring the very basics of this to you guys. So regardless of whether or not you're going to use rhythm control later on, rate control always has to be started in patients. Okay, unless you're planning on doing a rhythm control method very, very quickly, which it's possible, rate control is always started. Anytime the heart gets out of control, the risk for thrombi formation and emboli throwing increases. So you've always got to have rate control on as at least a consideration. When you consider rhythm control, though, and when I say rhythm control, really what I'm talking about is we're going to do something that stops atrial fibrillation, right? Either go the pharmaceutical route where you're going to be taking medications that continually stop the rhythm control, or you do some sort of ablation or cardioversion that stops the atrial fibrillation. The basics for rate control is that you use beta blockers and calcium channel blockers, right? That makes sense. We always talk about those as being reducing heart rate. Specifically for patients that have AFib with rapid ventricular response, diltiazem or metoprolol are commonly used. But like I said, we're talking about beta blockers, calcium channel blockers. Okay, so this is the main crux of the issue between rate control and rhythm control. Is does rhythm control really lead to less mortality? If you just think about it, then sure, there's a lot of positives of rhythm control. If you can control atrial fibrillation and therefore you don't have any risk of, or at least you have just a normal risk of stroke, then patients don't have to be anticoagulated. And if they don't have to be anticoagulated, well, that reduces their risk for bleeding. Okay, so that's kind of why rhythm control has always been favored in the past, because instead of just living chronically with atrial fibrillation, why not actually just stop atrial fibrillation? Okay, and probably the biggest study to date, and this is almost 20 years ago now at this point, is the atrial fibrillation follow-up of rhythm management study, and it suggested that when you looked in total, it didn't help improve mortality to go with rhythm control. And remember, if we're talking about rate control being, patients that have to be on, something like a beta blocker, that's a lot safer than patients that have to either go through a open heart procedure or, catheter ablation. and those really kind of nasty rhythm control drugs. Amiodarone is probably the most effective atrial fibrillation drug, but it is not good for you. It's got a lot of side effects to it. Again, if you've already gone through some cardiology, you probably noticed that one of the prominent side effects of any anti-arrhythmic drug is arrhythmias. So it's kind of a narrow line that people are walking when they're on these medications. So again, the idea was, well, if we can get people with rhythm control either permanently or with medications that just keep them in NSR, well, then do they need anticoagulation? But then the other side of the coin is when they studied how many people actually had strokes that had AFib, the highest percentage of the people were the ones that weren't on anticoagulation, okay? Which, right, it suggests that patients should be on anticoagulation even if they've already gone through rhythm control. It's a really difficult situation, and that's why there's a lot of controversy on which one is really better, right? Rhythm control definitely is a more aggressive way to go, but now it kind of looks like the benefits might not be there to back up the risk. Again, this isn't to say that it's not out there, it's a very difficult decision to make. So when do people tend to consider rhythm control? Well, one of them is when patients become symptomatic. Which is going to be more common with patients that have valvular disease, or if they just happen to have a rapid ventricular response. So then rhythm control tends to be considered more often there. So the other consideration is, are patients likely to stay in non-sinus rhythm? And that's the tricky part, right? Because the whole point is you have to be able to assume that you're going to stay in non-sinus rhythm. Generally, if patients are in normal sinus rhythm, if patients are in normal sinus rhythm for 3 months, then the assumption is, okay, maybe they don't need anticoagulation at that point. So it really becomes a question of how likely are they to go back into atrial fibrillation even though they've been in normal sinus rhythm for a while. Younger patients tend to stay in NSR. Patients that have a more recent onset, which means that they're earlier on in the progression of the disease, they tend to stay in NSR. Okay, so older patients with comorbidities and have long-standing persistent atrial fibrillation tend not to go through the rhythm control. So you can see it kind of comes into an interesting situation because patients that tend to be symptomatic are the ones with the more long-standing disease, but surgical ablation and catheter ablation tends to be less useful in patients with long-standing persistent AFib. Okay, so you can see there's a conflict going on there. If patients are in long-standing AFib, that's suggestive of having atrial tissue that's just littered with lots of different automaticity sites, which, if that's true, how can you really ablate all the sites that need to be ablated without causing a hypotensive situation where there's just, like I said, there's hypocontractility, okay? When rhythm control has to be considered, though, again, 2 basic ways. You do pharmacological, which amiodarone tends to be the most common one that's out there. You see a lot of sotalol too. And then the procedures include either ablation or cardioversion. Now, ablation is going to be your permanent, the so-called permanent treatment of AFib, whereas cardioversion is just to get patients out of atrial fibrillation and is not meant to be a permanent cure for AFib. So now let's talk about the stroke risk management, which again, it's not specifically related to the atrial or to the arrhythmias other than arrhythmias cause these, right? But the pathology tends to be just associated with it as opposed to directly correlated to it, or directly because of it, I guess. And the reason we have to talk about this is these are patients that are going to be on these medications for a long time, and everyone that has long-standing AFib is going to be on these medications, which they are dangerous medications. So we've got to be at least familiar with the strategy behind using these things. You'll talk a lot more about these in specific when you go over them pharmacology, but I just want to bring them up here. So antithrombotic therapy. When we talk about antithrombus, we're just talking about decreasing or preventing thrombus formation, okay? And there's two basic pathways to do that. There's anticoagulation, which is going to be specifically slowing the clotting cascade. Those are things like Coumadin, heparin, and Xarelto. And then the other pathway of antithrombotic therapy is antiplatelet. And that tends to be more mild, okay? So it's not slowing down the coagulation cascade, it's reducing the amount of platelets or reducing the platelet clumping that leads to coagulation. So these are more common medicines like aspirin and Plavix and things like that. Antiplatelet therapy tends to have less bleeding involved with it, or less risk for bleeding, but it's less effective as an antithrombotic therapy. Whereas anticoagulation has much more bleeding issues with it and much more monitoring that has to go on, but it's more effective as an antithrombotic therapy. So that's kind of the basics of those. And you know, we talk about them here, but we'll talk about them for lots of different diseases too, right? For patients with atrial fibrillation, the general choice is to go with anticoagulation. You know, in the past, there's still a recommendation that some very mild, if patients are at mild risk for stroke, that you can go with antiplatelet therapy, but it's generally considered now that anticoagulation is the way to go. So how do you choose who gets anticoagulation then? Okay, because you do have to be selective. A lot of it's based on this CHADS-VASc score. And it's another one of those scoring things, but really it's just a way to remember the different parts that equal up to the score. So if patients have congestive heart failure, hypertension, if they're 75 years and older, that's 2 points. 1 point for diabetes, 2 points if they've had a previous stroke. I mean, that makes sense, right? That's if you've had a history of the thing you're trying to avoid, that's not a good thing. And then 1 point each for vascular disease, age 65 to 74, and being a female actually confers risk too, 1 point right there. And that's the difference from the CHADS S2, where it really didn't take into account that women tended to have a higher risk anyways. So the big thing that wasn't included was that, yeah, women that were 66 years old had the same risk as a man that had a stroke, okay? But because of the way that it was calculated, those women weren't anticoagulated. So it's a big improvement on, you know, who gets covered with anticoagulation. So this is how it's scored. If you have atrial fibrillation, you go through the CHADS-VASc scoring list, and if you get 0 points on any of these things, right? So first off, it can only be men. If you have 0 points, then oral anticoagulation is not. It's not that it's not appropriate. It's just it's not required. Okay, or it's not recommended. For 1 point, anticoagulation possibly. Okay, so this is the big point here. The 1 point, you can be anticoagulated, but you don't have to be. For anyone that has 2 or more points, it's definitely a high recommendation for oral anticoagulation. And you probably look at this and going, that's really not that helpful. And yeah, it's difficult. It's difficult to make this decision because we're not just putting patients on aspirin. We're not just putting patients on a beta blocker. We're putting patients on things like warfarin, right? Not only is it a high risk for bleeding, but they still have to be careful taking it. And there's a lot of pilot error that can be involved. Eating spinach and all these things that can change your vitamin K levels that change your INR. So it's a difficult type of decision to make, and that 1 point is where a lot of medicine takes place, where a lot of patient preference takes place. And it's, yeah, like I said, it's difficult. It's beyond kind of the scope of this class. Another thing to note is that this is for non-valvular atrial fibrillation. All patients with atrial fibrillation with valve dysfunction should probably be anticoagulated, okay? Because for non-valvular atrial fibrillation, the only nidus for thrombus formation is going to be the blood pooling. But in patients with valvular dysfunction, those are also sites that can be a nidus for thrombus formation, because it's basically endothelial dysfunction at that point. So you just make sure that you're talking about non-valvular AFib. Remember, Joe had non-valvular AFib. A change from the older recommendations, there was more recommendations that antiplatelet therapy was okay for low-risk patients, but it's not as recommended before. You'll still see it out there, but it's just not part of these 2014 recommendations. So yeah, I don't want to just go over this part again, that the one point is controversial. I brought this point up again because when I write exam questions, these are controversial issues, right? And if you go to 5 health providers, 3 of them are going to think one way and the other 2 are going to think a different way, and they're, hopefully all 5 of those people are going to agree that the decision making is rational, right? That there's not like some blatant misuse of medicine and guidelines at that point. So that really makes it difficult to ask questions, because a lot of it does have to do with patient preference, right? And a lot of it has to do with health provider preference. So I tend not to ask questions on the one point thing and say, hey, do you think it's anticoagulation or do you not think it's anticoagulation? I tend to focus on things that are the obvious, you've got to understand these things and here's the correct answer. So on exam questions, I'm not going to be tricky. I'm going to put in it's going to be a 0 point or it's going to be 2 points. Okay. Having said that, when I give you those guiding questions, because they're not scored and they're not, it's a low risk thing, I tend to give you more difficult questions like that for those guiding questions, because I do want you to think about things. Just because I don't think it'd be fair to ask on a question doesn't mean I don't think it's fair to think through it. Okay, so with those, you tend to see questions with these topics, like I said, the guiding questions, you tend to see a little bit more difficult questions, but exam questions, I tend to be more concrete about them. Another more recent change in atrial fibrillation management, especially with the stroke risk management, is the preference of the non-vitamin K oral anticoagulants like dabigatran and rivaroxaban and apixaban and doxaban. It was really the standard was to use warfarin and Coumadin because it was just so effective. And not just was it so effective, you could monitor it with INRs, and then also you could reverse it easily too. But because we actually now have FDA approval for, and this is just within the past few years, for reversal agents for these newer oral anticoagulants, that's why they tend to be recommended. So rivaroxaban and apixaban have the reversal agent with andexanet alpha, and then dabigatran is reversed with idarucizumab. Patients that with mechanical heart valves, though, or severe mitral stenosis, still preferable to use warfarin, just easier to control. The difficult things with these newer anticoagulants is that it's more difficult to monitor them. There are labs to monitor them, they're just not as available. Again, the choice of anticoagulation tends to be beyond the scope of this this curriculum, since we focus on family medicine, but just to be aware of the different names out there. So that's basically it for this topic. It's a big topic, and again, this is just kind of like an introductory talk to get us familiar with some of the strategies. Just make sure to use the guiding questions to kind of help you through the topic, and if you have any questions, just let me know. Thank you so much.